Okay, so here we go. We've done the overview, so we kind of know what this book has in it. So now let's figure out how to read this sucker. So let's go. First, let's talk about some of the symbols that's in it. So I want to go to the very first page of the tabular section, which is your chapter 1. So this is the last page of your external cause index. This is the first page of your tabular section. Remember, we have an index section and a tabular section. So here on this page, I want to talk about all of the stuff that's on here. And we may have to change a page or something just to get all of the little terms. So down here in the box, we have our symbols, or our what they call conventions. So let's start with unspecified code. That is highlighted yellow. The reason that it is highlighted yellow, and every unspecified code in this entire book will be highlighted yellow. The reason it's highlighted yellow is because it's unspecified. And the insurance companies do not want you to use unspecified if you have a better, more specified code. So it's just flagging you. So depending on what you're doing or coding, unspecified may be the best that you have. If you have the capability of querying doctors and it's between unspecified and you know that that doctor's got to have something more specific, I would query the doctor and get something more specific. But that's what it's doing. It's just flagging you, saying, are you sure you want to do this? Are you sure there isn't something more specified? Like coding cholera unspecified when you know that it's cholera due to Vibrio cholerae 01. You know, if you had that documentation, you would need to code the more specific code opposed to the unspecified, which ends in 9. Other specified code. So if you look at A04.8, that is other specified. So what that's telling us is we're under our 3-digit category, A04, other bacterial intestinal infections. And you're saying, if you're going to use other, then you're saying it's not enteropathogenic, it's not enterotoxigenic, it's not enteroinvasive, it's not enterohemorrhagic, it's not other intestinal E. coli, it's not Campylobacter, Pylobacter. It's not enteritis due to Yersinia enterocolitica. You're really pushing my it's not enterocolitis due to C. diff. It's none of this. What you're saying, if you want to claim A04.8, other specified bacterial intestinal infection, that means in your documentation that the doctor has given you, he has specified something other than what is listed here. He didn't just say they have a bacterial infection of the intestines, because then that becomes unspecified. But he said they have a bacterial infection due to blah, 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 and it's not one of these. So that's how you would use other. You do have this, so other means you do have the specificity. The book just didn't list it for you. Manifestation code. I see no manifestations on here. So let's go till we find one. Let me look here. I'll come back to that page, but I want to find a manifestation for you so that you can see examples. Ooh, manifestations are tough. If we were in class, somebody would have already found it before me. Let me just try to find one. Okay, let's go to code G91. I'll give you just a second to get there. G91, hydrocephalus. G91. So the G91 is our 3-digit category code. So when the book talks about a category code, these 3 digits that are way out here, G90, G89, G83, G82, those are our categories. If it's 3 digits, it's our category. So we're under category G91. I'll tell you what that 4 means in a minute. But down G91.4 tells you hydrocephalus in diseases classified elsewhere. So that's telling me that this hydrocephalus is a manifestation caused by another disease. And then it goes on to tell me what to do with that. So it's highlighted telling me it's a manifestation. And now it's telling me what to do with that information. And the book tells me, and the book's smarter than we are. Always, always remember that. Don't ever think you're smarter than the book. Nobody is. Code first underlying conditions such as congenital syphilis, neoplasm, and a deficiency. So if one of these, most likely they're the most common reasons for the hydrocephalus. If one of these is pertinent to what caused it, then you're going to code it first. That's telling you your sequencing, and then code your G91.4. So manifestation code means the patient has this current manifestation because of another disease. And you probably are going to have to code that other disease first and then the manifestation. Always do what your book tells you to do. Always, always. It's super duper smart. The book's super smart. Okay, back to our chapter 1 page. Newborn. This is self-explanatory. Remember I was talking in the other video about the male and the female? If you see an N beside a code, that can only be used for a newborn. So let's go to our P section. Remember, P section is for our babies. So let's go to the P's. Let me get there. Very first page of the P's. Let's see what code. We've got to find an N in here for a newborn. Bet you guys have already found one. I'm pokey with stuff like this. Well, I didn't see any N's. So I guess off the cuff, I'm not going to be able to show you the N's. All of these already state newborns, so that's probably why they don't have an N on them. Okay. So we do the same way. N for newborn, P for pediatric, M for maternity, A for adult. Okay? Self-explanatory. We've already talked about the male and female symbols. So if there's a symbol, so you can't, so like a maternity code, if it has an M on it, you can't put that code on a woman that isn't pregnant, or you can't put that code on a man. An adult code, you can't put an adult code on a pediatric patient. I think there's a few exceptions to that, but generally you can't. You can't do a newborn code on a maternity code. You can't do a newborn code on an adult code, okay? Your black solid dots are new codes, so that means they're new from last year. So if you do not know your ICD-10 from last year, don't worry about the new code. Why waste yourself? Why waste that knowledge? You know, don't worry about it. Your triangles, just like in your CPT, revised code title, revised text. If you didn't know it before, don't worry about it now. Just learn it how it is. If you did have experience in an ICD-10, you might want to read this stuff because we may be using the code differently than we used to. Your notes. This is a good section. Surely there's some notes that I can show you. I know there's notes on 094 because we were just talking about it at work today. So let's go to 094, code 094. Right here, 094 is sequela of a complication, and there's your notes. So your notes section tells you, let me try to get that to where it doesn't glare so bad. Your notes section is just giving you a little bit of information on how to use that code. Okay, that's how it's designed. Includes, excludes, and excludes to. Let's talk about these. So let's do your includes first. And at the front of every, let me get this, the front of every chapter will tell you, well, I lied with that. Okay. So some of the chapters will give you a little bit of what your includes, excludes, and excludes to means. But let's look on this page to what they are. So here's an includes. So category code A02 includes means this other salmonella infections, these codes all include infection or foodborne intoxication due to any salmonella species other than the typhi and the paratyphi. So these codes include this blurb. So they're further defining what's in those codes. And excludes one means you don't code that here. It's not coded here. So A04, other bacterial intestinal infections, has an excludes one, which means anything after that is not coded here. So bacterial foodborne intoxications, not otherwise classified, not elsewhere classified, NEC, and tuberculosis enteritis are excluded from this area. They're not coded here. So you code them someplace else. So don't use codes here. If you're trying to code bacterial foodborne intoxications, don't code it from here. Go to A05. Okay? Excludes to is kind of the opposite. Let me find an excludes to. I probably have to turn the page. Here we go. So under A06, excludes to, means not included here. So so this is amoebus or amoebiasis. So maybe you're looking for the B60.1 as well as, so your patient has acute amoebic dysentery. So A06.0. But they also have this B60.1, the acantha amoebiasis. So they could have both of them. So your excludes two means you can code here and you can go pick up this other code if it applies to your scenario. Whereas your excludes one, you cannot code them together. You have to go someplace else. Okay? Those are kind of confusing. The guidelines breaks this down some too. Now let's get into actual codes. So we've talked about your 3-digit is your category code. And if you see a 4 or a 5 or a 6 or a 7 out here where that red dot is, that means you have to go that many characters to get a valid code. So most category codes need more digits. There's very few category codes that are valid just as 3 characters. I'll show you one in a minute, but for right now, let's follow this. So A03 needs a 4th character. It says 4th there. So we have to go indented and find which one applies. Coding A03 alone does not render a valid code. Coding A03O, A031, A032, A033, any of those would then make a complete valid code. Look at A04.7. That has 5th by it. So it's already 4 digits, so it has to go to the 5th. So indented underneath it, they add a 1 and a 2. So again, A04.7 alone is not valid. Because it has a 5th character requirement, you have to go one more character. Let's see one that we have to go to the 6th. It's the same principle. Here we go. Let's go to C. Get this over here. C4431. I'll give you a second to get there. C4431. That has a 6th character. So if you go above that, C44.3 had a 5th character. So then when you got to the 5th character, they want you to put another one on it. It's going to require a 6th. So you got to keep going. See how it's indented? So it's indented 3 times now. So the category for C44 is actually right here. There's your C44 category. But that alone is not a valid code. It's just a category. So your 6th digit, C44.30, telling us we have to go another. So we can add a 0, 1, or a 9, depending on what it is. So this is unspecified malignant neoplasm of skin of unspecified part of face. So if your documentation tells you patient has unspecified neoplasm of the face, then you would do C44300. If it tells you unspecified neoplasm of the skin of the nose, now you're more specific, C44.301. Okay, so that's how we go to the different, and you can go all the way to the 7th. There are times that you see a placeholder. Anytime you see that X in the 6th spot, we did see some in the drug table, that's just a placeholder spot because it's requiring you to go to the 7th character, and sometimes there's nothing to put in the 6th, so you do a placeholder and do an X. This is telling you, so you've got your 4th character, 5th character, 6th character, 7th character, and on your 7th character, sometimes you will have this extension X alert. Okay? Make sure that you're paying attention. The AHA coding clinic, that isn't going to mean much to you if you don't work for a place that has access to them. They're really expensive to have on a personal note. But all of them, you'll see like AHA 4th quarter 2017. That means in 2017, the 4th quarter, there was some type of guidance that the American Hospital Association put out regarding this code. And that's how ICD-10 gets updated. Always pay attention to your code first. That's that little finger pointing at you. Red finger saying to code first. Okay, let's turn the page. We have more conventions over on this other side. Down here. So you have some guidance on what's acceptable or not via Medicare to use as a principal diagnosis. Maybe it's exempt as a diagnosis if it's present on admission. These are typically principal and present on admission. That's lingo for inpatient. If you're coding CPC, which is outpatient, you probably will not see that kind of lingo. Questionable admission, again, this is talking about admitting into the hospital. Complication or comorbidity, sorry, I said that twice wrong. Again, and your major complication or comorbidity, your CC, MCC exclusions, these are all very much geared, all of this is geared towards your inpatients. So if you're going for your CPC right now, I wouldn't worry about this stuff until you potentially encounter some inpatient charts, that kind of thing. HCC diagnosis code, we are seeing now some of the publications in the last few years putting HCC designation on there. That helps. You can see it, there's one right there. That helps for those of us who do risk adjustment coding. We do have crosswalks. I don't ever look at the HCC in something like this, but it's nice to have the added information. We also have RxHCC information. These two are geared toward risk adjustment coding. You would not ordinarily see them if you're coding for a physician office, something like that, unless they're starting to track their chronic conditions and need to track their HCCs. The tip, there's some coding guidelines or guidance that can help you. The eyeball, they have started, and you can see an eyeball over here under code A18.0 that's telling you, look in the official guidelines, the first part of your book, and it tells you the and it's in section 1A14. So that's kind of a little bit of an added guidance to, hey, if you're coding from here, do you remember you have a guideline for this? Do you need to read it again and see what it means? That kind of a thing. Okay, so now let's go look at these guidelines. So beginning on page 1 of whatever book you have, it's all the same. Page 1 is your official guidelines for this year. Now, we did have a little bit of a trouble with publishers last year putting out the year before's guidance and then having to send external guidelines. That kind of got fixed. But this is the actual, all of your guidelines will always go from October 1st of the year until September 30th of the next. CPTs update January 1st every year, but your diagnosis codes update October 1st of every year and go for a year. So this is your table of index or table of contents. Table of contents. Talking without thinking. Happens a lot, believe it or not. My family would tell you. Your section 1 has all of your conventions, coding guidelines, what all of the symbols and conventions that we just went over means, what NEC, NOS. This is a really, I would urge you to read over this, make your notes. You may have to come back here several times. This gives the guidance of the other. Remember the scenario I gave? Your documentation has a specified other reason. It isn't unspecified, but the book just doesn't list it. That's how you would use your other. Talks about your includes and excludes notes. Your placeholder with the X. We've gone over all of this, but this I would go back after listening to me, or read it first and then listen to me. Or listen to me, read it, and then listen to me again. I don't know. That's a little bit too much listening to me. But this is all of the information I'm giving you written down. I'm just kind of talking you through it. Your and your with guidance. With anymore is considered linked. And we'll talk about diabetes in just a minute. Code also notes, see also notes. What does that mean? So we've talked about the red finger that says code first. That's giving you a sequence. So if you see the red finger and it says code first, go code first, that other code, then come back and code the code you're looking at. Your code also means code me first, then code also whatever they have listed. So this is giving you guidance on how to sequence your diagnosis codes. And it's sadly important. Risk adjustment world, it doesn't matter. Signs and symptoms, this is telling you that you use signs and symptoms until you have a definitive diagnosis. Then you do not ever code the symptoms if you have a more definitive diagnosis. So let's talk through a couple of examples. Patient comes in with a fever and cough. So you would be coding fever and cough until you had something better. They're diagnosed with bronchitis. So now you don't code fever and cough anymore because you code bronchitis, because a fever and a cough would be inherent to bronchitis or to pneumonia, whatever it is. Patient comes in with swollen glands under their arms, swollen glands on their neck, and so that's lymphadenopathy. So you're got acute lymphadenopathy. So that's what you're going to code until maybe they get a diagnosis of lymphoma. So then you would not code lymphadenopathy anymore because swollen lymph nodes is a sign or symptom of lymphoma. So you would only code the lymphoma now. So what does that mean? That means you need to get really familiar with your disease processes, especially if you're going to code risk adjustment. I say this every single day. You really have to know your signs, your symptoms, how your disease progresses, what are the signs and symptoms of the diseases, and then try not to bleed your symptoms over into your diseases. Easier said than done. You know, some of that comes with practice. But anyway, that's what that means. You can code any signs and symptoms of a related diagnosis until you have the definitive diagnosis. One of the rules for outpatient is you can only code definitive. You don't code suspicion of, consistent with, ruling out. Those are not confirmed diagnoses. We only code confirmed diagnoses. I had this today with one of my team members. Okay, here's your code first. Guidance telling you that you go and code whatever it's telling you to code it first, if it applies. How do you sequence acute and chronic conditions? If you have acute congestive heart failure on chronic congestive heart failure, that actually is a combo code, so that wasn't a good, that wasn't good because you can get acute on chronic diagnosis code, so scratch that. Sorry, I got risk adjustment on the brain. You have acute renal failure on chronic renal failure. So you would code the acute first, which is N17.9, and then you would code the chronic next. Okay? So acute, if you have something that's acute and chronic, they're the same thing, but it's an exacerbation of it. It's in an acute phase now. On top of an existing chronic, you always code the acute first. Sequela, I've already said that word once. That's the new term for the old-timey late effect. So, what's the most common thing that we have residual effects of? Strokes. Patient in September 1st has an acute stroke. We code that as an acute stroke while they're in the hospital. When they go home and they start physical therapy, rehab, whatever it is, they come back to the doctor wait. So let me go back and tell you what the sequela was. September 1st, they had a stroke that affected their entire right side. So the stroke, quote, resolved or got past the acute phase. They go home, go to rehab, physical therapy on that right side, and come back to the doctor in November. All the physical therapy is done, but they still have residual weakness in their right arm and their right leg. That is now considered a sequela or a late effect or a residual of the stroke. So you would code the stroke out of the I-77 probably, and then you would code that right-sided hemiparesis or right-sided weakness out of the I-9 series. So that's a sequela. That's just gives you a little bit of, not much, that probably didn't help you too much. Laterality, let's talk about that a little bit. In ICD-9, we did not have the ability to make anything right or left. With ICD-10 coming around, we can now do lefts and rights of stuff. So if you have the information that it's a right ear infection, put it in the right ear. Or if it's bilateral, maybe they have a double ear infection, put it in both of the ears. So we do have that laterality now that we didn't used to. I'm not reading all of these guidelines to you. I cannot tell you how important it is to know these guidelines for your board. You do not want to have to be sitting here reading these guidelines the day you're bored. I'm telling you, you do not. vitally important to how to sequence, how to use, how to correctly and accurately code from the ICD-10. There's guidelines in a lot of situations that these will all help you with, but I'm not going to read them all. Okay, let's start doing some chapter-specific guidelines. So chapter 1, remember that was your infectious and parasitic diseases. There's some very concrete guidance on how to code HIV and AIDS. You code only the confirmed cases to HIV. So you have two different codes to choose from. You have a Z code, which is asymptomatic HIV, and you have a B20, which is AIDS or symptomatic HIV. So how do you distinguish between them? We generally code to asymptomatic unless the patient has had an AIDS-related illness. Once the patient has had an AIDS-related illness, they are considered converted, and they will always be the B20. They won't ever be asymptomatic again because they had the symptoms from an AIDS-related illness, and they become a B20. Sequencing how to code AIDS. Say you have a HIV patient that breaks his wrist. Has nothing to do with HIV or AIDS. So you would code, they have to go to the emergency room. They have a fractured wrist. So they go to the emergency room. The fractured wrist would be coded first because it had nothing to do with the AIDS. You would still track that Z21 or B20, wherever it was in their cycle of the virus, but you would not code it first. Consequently, if that HIV patient presented to the emergency room with pneumocystis or pneumocorini or pneumonia. I just had a brain. Maybe I said it right. Anyway, the pneumonia that's inherent to HIV or to AIDS patients, that would be what you coded first. And then that would be a sign, if they had never had an AIDS-related illness, that would be the sign that they were a B20 from now on. But these guidelines give you good indication or good guidance on how to code for the sequencing and how to put what forward first, sequencing. Your septicemia. If you have sepsis and it's considered severe, if they document it as severe, you've got to add an extra code, the R code, and then you need to track whether or not it has organ dysfunction or not. And all of that would be gleaned out of the information. Your doc would be documenting all of that. So you would just have to know your guidelines well enough to be able to, and maybe even come back here and kind of read up on it real fast to make sure you're gathering all of the codes that you need. This is telling you that if you have severe sepsis, it's gonna require a minimum of 2 codes, and then it gives you the sequence that you're gonna code. Sepsis due to post-procedural infections, that gives very clear guidance. You have your MRSA, you have your MSSA, so R is resistant, methicillin resistant Staph aureus. Your MS is methicillin susceptible. They're opposite. So really make sure MERS is the bad one, because it's very hard to treat. Takes really strong antibiotics to treat it. We're into chapter 2, your neoplasms. Just like with the sequencing of the HIV and the AIDS, your neoplasms gives you very good guidance on your sequencing. And they've even added a table here, which I think is fantastic. You don't even have to get bogged down in a lot of the wordy stuff once you've at least read it once. Read it and get to know what's here. But then you can just find the reason for your encounter, and then it'll tell you how to code it. is just a fantastic table. That neoplasms sometimes can be very difficult to code when you have a lot going on. Maybe the patient's had chemotherapy or radiation and now is having all of those symptoms, and they're coming to the emergency room because of all of the symptoms to the treatment they're getting. How do you sequence that? Because it's not really the cancer bringing them to the emergency room, but they wouldn't have had the chemo and the radiation without the cancer, So this gives good guidance on the scenarios and how to sequence those. All of this. It's very, very good guidance. Chapter 3 doesn't have too much. Chapter 4 is your endocrine. This is your diabetes. So there's a few key guidelines. Most of the things that I'm talking about, the guidelines are just kind of the high level. They're not too far down in the weeds. Probably good information that if you were going to interview for a coding job or take a test for a coding job, some of this stuff would just automatically be on it. Like what? So we know there's a type 1 and a type 2 diabetes. So if your provider, your doctor, does not document the type, what do? Is it type 1 or type 2? Well, your guidelines right off the bat tells you type 2 is the default. That is key. Type 2 is the default. I promise you that'll be on your CPC board. Any employer with any kind of sense is going to make sure that you know that. And if you don't know it, they're going to think, I don't know if they're such a good coder after all. So that's very, very, very basic and really good information to know. Because we have an increased use of insulin pumps for diabetics now, there's a couple of scenarios for underdosing and overdosing, accidentally, of course, that will help kind of guide you how to code those scenarios. Your secondary diabetes, this gives you good guidance on the scenario that you might have for your diabetes. Again, we have a great decision tree here. Would probably be smart for you to study it. You start here and then you just kind of follow all of the decision tree. Key on your use, abuse, and dependence. And this is across the board. If your doctor says the patient uses something, then that's all they're doing is using it. If they're saying that they've abused it, then clearly they're using it, and now they're to the level of abuse. So you would not code a use anymore. You would code the abuse. If your doctor says that they have a dependence on opioids, a dependence on alcohol, a dependence on nicotine, they're past the level of just using or abusing. They're into dependence. So that's kind of a progressive way. So the point of that is you always code to the highest. So if you have documentation of dependence, don't mess with abuse and use. You wouldn't code these two because they're already included in your dependence. That coding to the highest is kind of like, remember in CPT, we talked about the colonoscopies, all of the scopes, and you always code to the furthest extent. That's kind of how it is too. Same thing with your burns. We'll get to burns in a minute. But say I had a first degree on my forearm, a second degree, and a third degree, all on my forearm. You would code to the highest degree. So that first degree you wouldn't mess with. The second you wouldn't mess with. You would only code the third degree. And then do it by, then combine, do it by size. Okay. Chapter 5, mental health stuff. Not a whole lot in here, more than it used to be, because we've only had stuff for a few years now, so it's kind of nice to have something in here. Nervous system, there's a lot of pain guidance. There's a lot of folks out there with chronic back pain, chronic neck pain, knee problems, chronic pain that involves having stimulators inserted, having grafts, implants, that kind of stuff. Your nervous also will have your post-op pain. So if you're coding a scenario with post-op pain or coding a scenario, just some kinds of general pain or general neurological pain, I would come here and read this specific to what you're coding. Chapter 7, eyes. Again, not a whole lot to pull out of here. The few things they do have here about blindness, different glaucoma, that's mostly what they have here, so that would be pertinent if you were coding that. Chapter 9, this gets into your cardiovascular, hypertension, that kind of thing. We've got a great tree over here, but first let me tell you a little bit about your hypertension. So there's some very, very strict rules that this is, again, information that if you were on an interview or taking a coding test, you would probably see this on there. So I would learn this and code it likewise. So hypertension by itself is coded to I-10. That's what this tells you. It's coded to I-10. But if you have hypertension with heart disease, then, and that heart disease has to come from an I-50 series or an I-51.4 to I-51.7 or 0.89 or 0.9. If you have these specific heart codes and you have hypertension, then you can combine them and you're going to code the hypertension to an I-11 instead of an I-10. So let's look at that. Let's look at that back here. So everyone go to I-11. Let's go to I-11. Okay, so here we go. I-11, and we're going to have lots of notes in here. So this is I-10 through I-16 is your hypertensive disease. It says use additional code to identify. So this is telling us once you've coded from in here, if any of these other things apply, go on and code them. So it's talking about tobacco use. So your I-10 is your essential or your primary hypertension. Your I-11, what we were talking about, is your hypertensive heart disease. And so I-11.0 is with heart failure. I-11.9 is without heart failure. So if you look under I-11.0, it says use additional code to identify type of heart failure and gives you that I-50. So you would code, if you've got that hypertension and maybe congestive heart failure on that same date of service, then you would code your I-11.0 here and then also pick up your I-50 whatever, 0.9 or whatever it is. So you see how we have the guidelines that then tell us how to use this. And then we come here and it's gone on and given us little notes on how we should be coding it. Okay, so let's go back to our guidelines. So we were on our hypertension because we're going to do the same thing in just a minute. Keep your hand where that I-11 was. So we've done hypertension with heart disease. Now we've got hypertensive chronic kidney disease. So again, if you have hypertension on the same date of service that you have CKD, unless the doctor tells you they're not related, which probably is not going to happen, you're going to combine them. So you're going to code your hypertension to the I-12. So far we have regular hypertension as I-10. We have hypertension with heart disease as I-11 point something. We have heart disease, hypertension with CKD or chronic kidney disease as I-12 point something. So let's go back. Let's look at our I-12. So here's our I-10 for regular hypertension. I-11 if our hypertension has our heart failure or has any condition I-50 point whatever to I-51.4 to I-51.9. And then your I-12, and see it's telling you to look at your guidelines. Look up your guidelines. And it's going to include any condition in N18 and N26 due to hypertension. So here's our I-12.0, hypertensive CKD stage 5 or end stage, and then use additional. See, that book is telling us everything we need to do. We just have to read the book. And then I-12.9 is used if your CKD is stage 1 through stage 4. And then it tells us here to go pick up that CKD, whatever the stage is. Okay? And then our last hypertension is if your data service or your patient has hypertension and heart disease under these categories and CKD under that N18, then you code it to an N13. So we have I-10, which is plain old hypertension, I-11 point whatever for hypertension with heart disease, if their heart disease falls under that category. Our hypertension with CKD as I-12 point whatever, as long as we have CKD. And then we have hypertension with heart and CKD combo that you code to the I-13. Okay? Key to know this. I would study that. It'll come second nature to you. This happens to be a great decision tree. It goes over everything I just told you. You start with your hypertension up here, and then you just follow it down and answer your questions accordingly. It is very, very good. We did talk a little bit about the late effects of a stroke. So this is telling you that you do your I-69 category is talking about the sequela or the late effect of your strokes. Oops, I am just tearing that crap out of that. Your acute MIs are in here. Subsequent acute MIs, that means that you've had an MI that is acute for 4 weeks. You code it as an acute MI for 4 weeks. And during that 4 weeks, you've had another one. So within the 4 weeks, you've now had 2. That's what subsequent acute MI is. Does give you a little bit of guidance on specific types of myocardial infarctions and how to code them. This would probably be a good resource. Respiratory system gives you a little bit of definition of what the acute exacerbations are. Influenza, ventilator, pneumonias, not too much, a few decision trees, not too awful much for the respiratory. Your skin gives you your pressure ulcers, some guidance on those, what to do with unstageable pressure ulcers, non-pressure chronic ulcers. Good guidance on all of that. Those are your L codes, L89 to L98, 97, something like that. Musculoskeletal connectivity, connective disease, not connectivity, whatever, crazy. Really know, remember we talked about laterality, knowing your left and your rights. Musculoskeletal really gets affected by left and rights because you've got left arms, left feet, right feet. Osteoporosis, what to do with and without a pathological fracture. Genitourinary, this is your CKD, how to stage them. Potentially, what. So if you're, this number 1, 14A1, I just had this QA in a chart the other day. So if the doctor gave you mild CKD, stage 2 actually goes to mild. Stage 3 equates to moderate. Stage 4 equates to severe. So the doctor doesn't anymore have to specifically give you the stage. If he gives you mild, moderate, or severe, you can get there. So that's what the guidance is telling you. Lots of OB pregnancy information here. Outcome of delivery, you're going to have a Z code. Z37 goes on the mom's chart. Z38, which when I turn the page we'll probably see it, goes on the baby chart. There again, remember I talked to you about not putting maternity codes on a newborn chart or newborn codes on a maternity chart. As soon as that baby's born, it has its own chart. It's the baby chart. So outcome, every delivery has an outcome, whether it's a good outcome, which is a normal outcome, is a Z37, or a bad outcome. They all have an outcome. So your Z37 series goes on the mom chart. Whereas your, do I have it highlighted? Yeah, we'll get there. Again, here I have your Z37 goes to the maternal. I even have that written down. Here we go. Z38 goes on the baby chart. I knew I had it. Here's another great, little bit easier decision tree. Some of the pregnancy codes just are daunting to me. Sorry, it's the truth. Everybody has a weakness, and pregnancy's fine. I can be pregnant, but I don't want to have to code it. Congenital malformations. We've talked, there's just a few guidance tips for that. Your symptoms. These, we've kind of already talked about symptoms. Most of this is very specific to comas or SIRS, death, you know. Your injury codes, something very, very important. Your 7th characters are either going to be A, D, or S. A means if your 7 characters ends in an A, then it's the initial encounter. If it ends in D, then it's a subsequent encounter. If it ends in S, then it's a sequela. So that's good to know. When you get back to these codes, looking at it, you'll have a table telling you, defining these 7th characters. So this isn't the only place you'll see that. You'll see that back with the actual codes. Your burns, sequencing of burns, it says here that you code to the highest extent. Here's a good decision tree. Burns generally require a few extra codes because you need to, when you're assigning codes, trying to see if I can find where it is rapidly. You generally need all your burns go from a rule of 9s, and you're going to need a code for the percentage of body area that was burned. So you would have your normal burn code plus a T code signifying by the rule of 9s, which you have that in the ICD-10 back with the burns, to be able to add up the percent of body area that was actually burned. You have some guidance on your poisonings. This is really a good table. This is your adverse effects. What was the nature of it? As in, did you have tachycardia? Did it make you delirious? Did it make you faint? Did it make you hyper? You know, what happened? Underdosing, toxic effects. Really good information. Your external cause codes. This helps you take this index. Remember the index of external cause codes? This index, and breaks down that you need a place of occurrence. You need an activity code. You could very easily have 2 or 3 external cause codes because you have to put them where they had the accident. Was it in their home? Was it at church? Was it in a grocery store? Then you have to describe they fell off a curb onto concrete. They were riding a bike in the park and fell on cement. You know, they were riding on a boat and fell off the back into water, you know, whatever it is. You have to really get specific and itemize it. And that's kind of what this goes through. This 21 section, this is a little bit about late effects, but this chapter 21 section helps to some extent cut down all of those Z codes, categorize them. This page here does a decent job of giving you an idea of all of what's back there. your history codes, your screening codes, your observation codes, aftercare codes, different status codes. The Z codes, in my opinion, are a little bit hard to get used to. I mean, I'm used to them now, but it was kind of a different way of thinking. So for me, it was not that easy to get used to them. I'm better with them now, but they bear some study, in my opinion. Okay, now we kind of are past the specific chapters and we're getting into selection of principal diagnosis. This would be for inpatient. Principal diagnosis is the lingo for inpatient. Additional reporting of diagnoses, again, inpatient. Outpatient is really more what we're geared for the CPC. This is great information, but you can't take these rules and apply them to outpatient, just like you can't take outpatient rules and apply them to inpatient. These are generic kind of rules. Your first listed is the lingo for outpatient, whereas principal diagnosis is the lingo for inpatient. This gives you some good information, specifically level of detail, chronic diseases. Well, the docs are supposed to always be documenting them, is what that's telling you. They don't, but they're supposed to. Ambulatory surgery, screening, health screenings, just some good information. Present on admission, again, this area is going to be for inpatient. We don't have POAs on outpatient. Yeah, right. No, I said that right. Good for me. Well, that's a miracle. And then there we are. Some of your publishers do have some practical steps for using the ICD-10. Now that we've gotten familiar with it, and if you do have this, you might want to read through it to see if you're getting as familiar maybe as what you want. It might be good for you. But then we're right into the illustrations, and you have whipped the ICD-10. Now all you got to do is practice. I would recommend, there's 2 or 3 chapters. Again, this is a 3-2-1 code it. There's 2 or 3 chapters. The 3-2-1 code it does really do a good job of breaking it down by sections of stuff. Skip the PCS stuff. But then if you have has your conventions, has you looking up stuff, how to look it up, how to use your tables, really does have some good examples of how to use stuff. So if I were you, I would drill and look up stuff. Just like with the CPT manual, we had the Coder's Desk reference. I have the Coder's Desk reference for the diagnosing. I find it very helpful. In fact, earlier when I said we had the 094 issue or research that I was doing to see how to use that code combined with a sequela, I came here. This is the first thing I did was come here. Wasn't that helpful for me, but that's how I use this book. I'm vacillating on how to use a code. I'm needing a bigger explanation of what that code even is. That's what you can find in this book. I love this book. Love this book. And you can usually use a year for a couple of years. You don't always have to be rebuying every year. So I would recommend you get this. So from an ICD-10 standpoint, I would now start doing exercises, getting used to the book, looking up stuff, looking up scenarios. Your keep moving stuff around, don't I? Your chapter 4 of your 3-2-1 coded book, all this does is break down those guidelines, chapter specific, and then drills you. That's what the whole thing is about, is drilling. It is a really long chapter. But once you get to the exercises, it's good. And chapter 5 is good drilling. That's just all it is. And honestly, once you get familiar with looking up stuff in the ICD-10 and how to use the index, you should be good to go. You should be good to go. So probably next week I'll do another video, maybe just drilling and looking up stuff in the index and how you go about using it. So I'll do another video in next week, using the book more practically. Maybe that'll help folks. Have a good night. See you in the next video.